I would like to now invite on stage Dr. Govindsamy Kumar Manikavel to moderate the question and answer session conducted by Dr. Bressler.
Okay, so good evening. I'm going to manage the questions. I'm going to be the moderator between the audience and Dr. Bressler. And I thank Dr. Bressler to have given one of the best talks. And he made both the ophthalmologist as well as lay public to understand diabetic retinopathy, and also said that how big a problem it is and how big it's going to grow and put the field of ophthalmology into all kinds of stress. Can we have this light cut off? Let's put the, okay. So, good evening.
Good evening.
I can't hear you. Good evening.
Good evening.
Okay. So I would appreciate if each one of you asks one question so that we'll give opportunity for others to ask questions as well. So I have to squeeze all the questions in the next 5 minutes. That's the time I've been given, and therefore I'll try to moderate it. And someone who's going to ask the best question will get 10,000 rupees, okay? Okay, it's a joke. Right, so let us first start with Dr. Sunita. Go ahead.
Good evening, everyone. Thank you, Dr. Bressler, for that lovely talk. And I like the heading, which is like, we are so close, but still far. So, I mean, just as you just said, right, 55% of the patients who had diabetes were never told to go for an eye examination. We have the same scene in India. When we see patients in our OPD, when we ask them how long you have been diabetic, they come up with an answer, 20 years. So we ask them, when was your last eye examination? The answer is, we never had an eye examination. So I still don't understand why a physician has never told them to go for an eye checkup. I mean, how do we sort out this problem? I do understand partly that, yes, they might be like losing the patient to some other physician, but what is the fear? How can we overcome this thing? Because this is actually one of the basic problems that even we are facing. That in spite of giving so much of awareness to the patients, to the population, to the society, and the doctors, we still face this problem that patients are not being referred to the doctors, to the ophthalmologists. So what do you suggest for this? Because we have come so close, but really we are far.
Yeah, it's an excellent question. And the study merely was designed to say, how big is the problem? And unfortunately, we learned it's a big problem. And I suspect, as I said, and your anecdote is in agreement, it's probably a big problem everywhere. So now, I think the next step is we have to get our colleagues together and brainstorm some ideas to find out, why is this happening? And it could be multifactorial. It may be that someone's telling them and they forget. It may be that we fail to continue to remind the internist or the nurse practitioner or whoever is taking care of them to continue to remind them every single time, is someone checking your retina? Because they can't do it. It requires either an image or a special photograph. So it can't be done by the person measuring your blood pressure. It's a unique measurement that has to be made, but they're not doing it. So I don't know why it's so high, and I think we can hypothesize some ideas, and the next step should be work all around the world and figure out what are the reasons. And they may differ in parts of the world, but I suspect there's a lot of common reasons as well. And if we can come up with strategies that will get even half of those people in, that's huge.
Thank you.
You want another one?
It's not a question actually, but because working with Dr. Natarajan has exposed me to a lot of ideas as to how to increase the compliance. So we have these, you just said that it can't be done by people who are measuring the blood pressures. So we have these non-Medriatic instruments which are handheld. Why can't a nurse be trained, right, to just take the image of the patient when sitting in a physician's room, send it to an ophthalmologist who's attached to that place, and say whether the patients actually need to follow up at this point of time or not. So that might tend to increase the patient compliance, cutting down the hospital visits. What do you suggest?
Sorry, Dr. Bressler. I would appreciate if you sort of repeat the question in one
I will
sentence.
repeat the question right. So the question was, how about trying something, for example, that has been tried around here, where you have a portable camera, you take a picture, send it to an expert and say, is there a problem there or not? This may work, and the challenges to that are you don't get the feedback right away, and you have to pay an expert to read it. Now, granted, paying an expert to read it is more efficient than having that expert go door to where you're going. Those are clearly different costs. And we want to brainstorm even outside of that box. We want to figure out, could we have that image just put on a secure site that trained people around the world have said, oh, when I have 5 minutes, I'm going to just, for a penny, look at the image, and I've proven that I can grade them reliably. And we want to see if there's innovative ways of grading those images instantaneously, so while that social worker is there, who's been trained to take that photo, not the ophthalmologist, not the fellow, not the resident, but just a technician who's been trained to do that, can right there and then say, this says you might have a problem, here's how we can connect you up. So these are potential solutions, and this is what we're thinking about.
Great. Thank you.
Thank you. You can go ahead. Yeah.
Yeah, first of all, a disclaimer, I'm not an ophthalmologist. Okay. And first of all, congratulations to Dr. Natarajan for his great work, and thank you, Dr. Bressler, for your talk. Like in oncology, we have tumor markers. So is there a way of predicting which patient will land up with diabetic retinopathy?
So the question is, as in tumors, there's often biomarkers that you can get from the blood and say, uh-oh, there's a problem in the prostate or colon cancer or something. We have something that's better or worse, I don't know. You can look right in the retina and tell, and it's 100% sensitive and specific in the right hands, but it requires a special image rather than a blood draw. So everyone can draw blood. Not everyone has these little devices, but we're getting there. And so we could draw blood to see if perhaps the person has markers that suggest they have a 40% risk after 12 years of getting retinopathy. But it's far more precise to just look in the eye. And that's why, in my opinion, a main direction to go is figure out very inexpensive, very efficient ways of imaging and say, is it there or not, and get that feedback to the person, and then get them to someone who can take care of it.
Maybe, do you want to add something about research in genetics and other fields?
Well, the genetics are very important. So that's not to take away from, is there a role for doing continued genetics research in this diabetic retinopathy? And the answer is yes. It is likely that there are certain genetic predispositions for some people when they're exposed to diabetes to be more likely to get the retinopathy. And this may give us clues as to how to slow it down or treat it in the first place. But we won't need those to diagnose who has it. We'll just look in the eye to say who has it. But the genetic predisposition may differ. There are people who have terrible kidney disease, and there's not a darn thing wrong with their retina, and vice versa. Terrible retina disease and nothing wrong with their kidney, and it's the same diabetes. So these are very fruitful areas of research to pursue.
Would you like to add a bit more about the other complications of diabetes as well, so that lay public...
Yes. So I mentioned the eye for two reasons. One, it happens to be what's on the top of most patients that have been surveyed, and that was just the U.S. survey I showed you, but in many surveys around the world. I can't tell you it's going to be true in every culture and every situation, but typically the loss of vision is the biggest problem. But there are many other problems that have to be dealt with, and some of them are social and some of them are physical. So the physical ones are that unfortunately the same blood sugar level can damage the small blood vessels not in the retina, but in the kidney. So that this is a very common cause of kidney damage or kidney failure, which secondarily can lead to very high blood pressure. This is a very common cause of damaging the small blood vessels in the heart, and a very common cause then of heart disease. And it can damage many other organs in the body. Now, the social factors are also important to recognize. So people that need to treat this day in and day out never get a vacation. Every day, every part of their meal, they have to decide how much blood sugar are they going to increase by eating this meal or that meal? How much medicine do they have to take because of it? How do I adjust that based on, am I very active today, or is this a quiet sitting day? And they never get a break from it. Now, there's a lot of research being done to try to have closed-loop systems that say, what's your blood sugar? Here's the insulin you need. But these are not perfected yet. We're closer. And that will at least perhaps release the burden for some people of having to check day in and day out. They could be giving a lecture like myself and have to stop and go to the side and check their blood sugar and inject with insulin and then come back up and finish the lecture. Fortunately, I did not have to do that, but that doesn't mean others, my colleagues that have diabetes, do have to do that. And that's just a tiny example of what it's like every day, every hour, every minute.
Yeah. Does it affect the nerve too?
Does it affect the nerves? So it has a problem with the nerves as well. So, for example, these small blood vessels nourish the nerves to your feet. And if you lose good circulation from the high blood sugar level to these blood vessels to the nerves to your feet, you may not feel when you bang your toe. You may then get an infection in the toe. It may not heal well afterwards. And so it can affect the peripheral nerves as well. Sometimes this just causes pain. So I think we've all had our sort of arm fall asleep, and as that's just the nerve not getting good blood flow, and it hurts a little bit. Well, imagine having that chronically all the time to your feet, and this is a problem that can develop as well.
Yeah. So,
can I have one more?
Yeah. Go ahead, please.
Okay. In India, we have this a problem where most of our majority of our population lives in the villages where they don't have access to an ophthalmologist. So is a good, tight control of their blood sugars adequate enough for them to prevent
So the point is not everyone has access to eye care, but they might have access to general medical care. And so is good blood sugar good enough? And the answer is it's important because it reduces the risk of getting this, but even under the best control, some people still get this damage after 10 years, 20 years, 30 years, or whatever. And so we need to figure out how to get this access to everyone. You know, one of the mantras that came out from the Gates Foundation last week is that they said, look, there are fewer poor countries than there were before, and that's true. And if you look at 1960 and you look in 2014, the world has really changed. And I think as our colleagues and physicians and public health people and other people working in the field, we need to come up with ways of making it accessible around the world. It may require innovative ways, where, as I said, you don't have the doctor there, you have the image there, and you have the image graded somehow, and the feedback comes there. I think we can do it. We have to recognize the problem, and now we have to convince, and there's a lot of good people in here and elsewhere in the country, elsewhere on the continent, and then elsewhere in the world that I think can take this on. And so here we are. We want to take it on with all of you.
Okay. So would appreciate questions from lay people as well. But we'll go with you now. Okay. You wanted to ask, right? Yeah. Somebody hand over the mic. Just a minute.
Just to take these two questions forward, actually the government of Maharashtra is making available portable fundus cameras to people in the interiors where they may have access to an ophthalmologist but not a retina specialist. And these are the images are being taken and they are being transmitted to telemedicine cells in medical colleges where we have to actually go and assess them and then revert back. Unfortunately, either they are not trained well enough to take the fundus photographs or the patients do not come back to them when we give them the diagnosis or ask them to refer them to the higher centers. So already in a small way this is being started, as you were just mentioning, but the training probably is lacking or patient compliance and follow-up. So